Good afternoon, everyone. We'll just give it a couple more minutes and then we will get started. Okay, we'll get going. So good afternoon, everybody, and welcome to the NARI Weekly Seminar Series. My name is Bianca Bridgenav. I'm standing in today for Jessica Cecil, who is our Education Coordinator, who's on some well-earned break. Welcome to our Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the lands on which we are meeting today and pay my respects to elders past, present, and emerging. So first, just a little bit of housekeeping regarding Zoom. We ask that you keep yourselves on mute unless you're a speaker. At the conclusion of the talks, we will have an opportunity for Q&A. If there's any burning questions that arise as the presenters are speaking, feel free to pop them into the chat. I'll collate them and we'll ask them at the end, or you can have an opportunity to ask them yourselves at the end as well. The chat tab is at the bottom of your screen. So that should hopefully be available soon. So we're very excited. We've got 3 speakers from Northern Health. We've got Dr. Campbell, Dr. Rebecca Jessup, and Dr. Loren Sher. They're going to present in order, and so what I'll do is I will introduce them each as they go along. They'll speak each for about 10 to 15 minutes, and then have a chance to go from there. So we'll kick off with Rebecca. So Dr. Rebecca Jessup is an early career researcher and currently works at the Allied Health and Staying Well Research Lead at Northern Health. She's got over 20 years of experience as a clinician and health services manager, and she's also an adjunct research fellow at La Trobe and Monash universities. So I think she's going to be presenting to us on understanding and addressing health literacy needs during a pandemic in migrant and refugee communities. So over to you, Rebecca.
Thank you so much, Bianca. I'm just going to share my screen. It's lovely to see a few familiar faces in the audience today, a few people I haven't seen for a while. So today I'm going to talk to you about a couple of bits of research that I've been involved in at Northern Health over the last 12 to 18 months, particularly focusing on vulnerable migrant and refugee communities, and how they're accessing and using health information during the pandemic and applying it to their own health needs. So the Northern Health community, most of you will be pretty aware, it's a very diverse community. About 40% of our population were born overseas, and we actually have over 182 languages listed at Northern Health. We have 106 languages, 182 countries of origin listed at Northern Health, and 90 religions. So it's a very, very diverse community. Australia-wide, about 30% of our population is actually born overseas, so it's actually a more diverse population than the national averages. So last year, we were a little bit concerned at Northern about how our most vulnerable patients, so those who were regularly accessing the emergency department and having hospitalizations prior to COVID, what was happening to them during COVID? How were they accessing information that they needed to support their health, and were they coming in if they were experiencing emergency situations? So we used the Department of Health and Human Services HealthLinks algorithm, which uses a particular set of criteria, including age, chronic conditions, 3 or more unplanned admissions and ED presentations in the past 6 months. And we use this algorithm to identify what we considered to be the most vulnerable group of patients in our population. And we stratified that sample to really try to get a lot of representation from our migrant and refugee community. So we selected 200 individuals, randomly sampled, but stratified for our top 10 languages. And we ended up interviewing 200 people with 115 from those languages. And 29 countries of origin were represented in that sample. And to give you an idea of why we were particularly interested in that pointier end group of people who use our health services a lot, we'd actually seen, and this is a representation of presentations to ED by week across the stage 3 and 4 restrictions last year. And in that Health Links cohort, which consists of about 5,000-ish individuals, we had a 36% reduction in that very first week where a state of emergency was declared at the end of March. And that was followed by 1% weekly drops over the course of the stage 3 and 4 restrictions. And to give you an idea comparatively, we saw a 15% initial drop from the non-Health Links population and about a 0.6% reduction in ED attendances. So we've seen this worldwide. There's been a massive reduction in ED presentations during the pandemic. But we actually saw a much higher rate from this group that were previously high system users. So we wanted to know how they were accessing information during COVID, whether they actually understood the information they were seeing, and whether it actually changed their help-seeking behaviour. And we actually used the WHO survey, Rapid, Simple, Flexible Behavioural Insights on COVID-19. And we found that the top 3 sources of information for these 200 vulnerable patients was television, followed by the internet, followed by family. We found that approximately 1 in 3 regularly relied on social media, and when they did, it was Facebook, YouTube, and WeChat were the top 3 places where they sourced that information. We found that people with limited English proficiency were much more likely to source their information from overseas television and from social media or family. So they weren't getting access to information from local sources as much as people who were proficient in English. And we found that those over 65 years were more likely to get their information from the television, whereas if they're under 65, they were more likely to access it from the internet. And we found that only 2 out of 3 respondents could actually identify that medical care was one of the reasons they were allowed to leave home during the pandemic. So one of the 4 reasons that we were allowed to leave home. And we found that 1 in 3 respondents had delayed or postponed medical care. And really, we had some really pretty astounding odds ratios. We found that respondents with limited English were actually 3 times less likely to have adequate knowledge of COVID symptoms, but they were 11 times more likely to believe misinformation. So they were much, much, much more likely to be, it's more than 11 times more likely to believe in information that was incorrect. What we did find quite heartening, though, was that when we dug a little bit more into people's reasons for not attending the emergency department and not coming to hospital for their health conditions, we found that some were actually deliberately avoiding coming because they were scared. And you can see some example quotes there about people who have actually had heart pain and avoided coming in. But we also had a really large group of people say that they were now able to access care more easily from their GP and from primary care providers through contactless telehealth and through picking up scripts contactlessly. And we actually found about 70% of the sample were reporting that they weren't actually avoiding care, they were finding care from alternative sources. So only about 30% were saying that they would not come into the hospital for any reason at the moment, which is still a little bit scary. So in a subsequent project, we've been working with the director of our Public Health Unit, which is the Northern Health arm of the Northeast Public Health Unit, Associate Professor Craig Boltons, and Cara Dixon, who's an MPH student at Melbourne Uni, actually led this project. And we conducted a 2-phase study that started with a rapid literature review to try to understand what are the current barriers and enablers to vaccine hesitancy, just generally. So we were looking beyond COVID and to generally in migrant and refugee populations, what were the barriers, and to identify focus areas for interviews. And then we conducted 9 semi-structured interviews with 16 participants. So some of our interviews actually consisted of 2 to 3 participants with community leaders and representative community groups that were representing newly arrived called communities. So we were particularly interested in the group that had arrived in the last 5 to 10 years that may have less social supports for health and less ability to find the information they need. And just by way of interest for you, we actually have the largest group of refugees in the state now. Most of the Syrian refugees in the state actually have settled in the Hume catchment, and so we actually have the largest and growing group of refugees and asylum seekers in our area. And so these are some of our key findings. I've pulled these out because these were the things that quite surprised us. That we found that from this consultation that most newly arrived migrants actually gain their information from peers, both directly and then secondarily through social media platforms. So we find that if misinformation is spread on social media, it's also spread by word of mouth secondarily. And we found that trusted sources, generally these populations do actually trust our government, even though they report that often they've come from countries where they don't traditionally trust their government. They also trust their religious leaders, bicultural health workers working in these community organisations, and really interestingly, teachers in adult migrant English programs. And I've highlighted that because that's become a bit of a focus for us, and dissemination of information has been through identifying key individuals in these programs that we've created as navigators, health navigators, who have been helping their own communities to come and access our vaccination services. We also found there's a lack of easily locatable, easy to understand and accurate and culturally appropriate resources on vaccines. Sorry, that's a bit of a mouthful. And that vaccine centres are potentially intimidating, and that these communities need supported pathways. So we do have a much more comprehensive strategy, but just to give you an idea of some of the things that have been done, Craig, who is our director of our public health unit, has been working with the adult migrant English program navigators, health navigators, to develop some resources that he delivers online to the community, and they've helped him to get the pitch right and the language right. And he has run a number of those so far. And we have a liaison person at Northern Health who meets groups of refugees and asylum seekers at our vaccination hub and provides them with support to come in as a group, because it's quite intimidating to come as individuals. And they're just a couple of the things we're doing, but we've been trying very hard to build our capacity within these communities, and we hope to continue to build it beyond COVID, so that in the future we have those relationships already there, and it becomes much easier for us to deliver information and we become a trusted source. I'd just like to very quickly acknowledge the research team from the Communication Project and also the Vaccine Hesitancy in the North Project, the interpreting team and the Office of Research that have all helped this. And we've received funding from La Trobe, the Northern Health Foundation, and the Health West Hume Whittlesey and Inner Northwest Primary Care Partnerships to do these projects. Thanks. And I'll stop my share.
Fantastic. Thank you so much, Rebecca. A really interesting and insightful project on how health services can build culturally safe and meaningful outreach and trust with communities. I've got lots of questions, which I'll save for later.
Great.
Our next speaker is Dr. Loren Sher. Dr. Loren Sher is a dual-trained pediatric and adult emergency physician and the Director of Pediatric Emergency at the Northern Hospital in Melbourne. She's also the clinical lead for the Northern Virtual Emergency Department project, which is what she will be talking to us about today. Over to you, Loren.
Thanks, Bianca. Let me get my PowerPoint up. Brilliant. I assume we can all see my PowerPoint. Maybe a thumbs up if you're happy.
Yes,
Brilliant.
we can. All good.
Thank you. Thanks, everyone. And thanks for the introduction. So hi, I am the clinical lead for Virtual ED, which is a project that we launched last year and we've been running since. And I thought I'd just provide you with a little bit of context for the project. So this came out of what we call a Sprints Idea Forum, where we were given the opportunity to pitch some ideas to the CEO about some issues we were facing. And at this particular time, when this was pitched, it was at the time we were going into the second wave. And we were noticing that one of the many problems we were facing as we were heading into the second wave was the issues around ED demand, social distancing in waiting rooms, which were difficult and tricky to manage prior to COVID. But also things that we were noticing were the delayed presentation of patients to the hospital, which was resulting in significant increases in morbidity and even in mortality. And a lot of this was due to fear of contracting COVID or a lack of awareness that they could in fact still seek healthcare during lockdown. Now, we knew that there'd already been a transition to telehealth within the service. This was particularly in the outpatient setting. And having surveyed our emergency department waiting room patients, we knew that at least 80% of our patients had the technology to support video conferencing or consultation. And so from this, an idea was born. Could we take technology, health professionals and community and develop a virtual emergency department for our patients? The idea was that we would have an electronic way for patients to enter into the system so that they could remotely register from wherever they were, be it at home or within the community. And this would be via QR code or a link. And this would somehow put them into a virtual waiting room where they could then engage and have a virtual conference with our triage nurses. And then if appropriate, they could then have a consultation with one of our virtual emergency physicians. And so we built in the process using various software tools, using RedCap as our registration tool, as well as a patient survey tool. Health.Direct as our preferred video conferencing tool, purely chosen because that's what we were using in the outpatient setting and we had familiarity with it. It was also free licensing during COVID. And then we did some research around some telehealth support tools for our triage nurses, realizing that we wouldn't be able to do a traditional triage without physiological parameters. And having researched, we chose a product that Ambulance Victoria are already using. And so we were quite happy that it had been validated both overseas, but also in a local context. And so we developed two pathways into our virtual ED. One is our patient pathway, which was the first pathway we launched. This is a self-referral pathway where patients are advised that they should not register if they have a life-threatening illness. So this is very much for non-life-threatening illness situations, but they're offered the opportunity to then register electronically, enter a virtual queue and have that consultation with the ED nurse. The ED nurse can then either direct them urgently into ED and in instances, if needed, dial 000 for them, or put them into a consultation with our virtual emergency physician who can then manage that patient with a view to discharge and refer back into the community, or bring into ED, but direct in many instances through different pathways to try and avoid ED where possible. The second pathway in is our healthcare professional pathway. This is a direct pathway that bypasses the triage nurse and offers direct health professional to health professional consultation. Again, using a different electronic registering link, again, entering the virtual queue to see the EP. At the moment, in terms of our healthcare professional pathways, we offer this service to our primary healthcare network, GPs, as well as acute care centres and our residential aged care as a bridging when residential inreach are closed. So we launched last year, October, offering a daily shift from 1 till 9:30, and that time correlates with our peak presentation times to the emergency department. As of yesterday, that has just been extended to 11:30 to try and meet increased demand during this lockdown, as well as try and assist with some of our COVID positive patients in the community. It is a completely separately staffed service. So we have one clerk, a triage nurse, and an emergency physician assigned to the shift. And ultimately, the aim of the project was to see if we could establish diversions. So could we keep a significant proportion of our patients away from the emergency department and manage them purely in the community? Could we do what's called redistribution? So get those patients that do require emergency care, but perhaps not imminently, get them to come in at times when we know that the emergency department is less busy. For those who do come in, could we streamline their care and where possible bypass the ED, for example, pop them straight into a short stay pathway? And with this reduced clinical incidents, particularly relating to do not waits and representations. And so apologies, this data is about 2 weeks old. Done about 2 weeks ago. So it's a little bit underdone for August, but as you can see, we've had a steady increase in our presentations, and we're near reaching the 4,000 mark in terms of total presentations seen. Approximately 30 to 40% of patients on any given month are pediatric, and the other percentage is adult. In terms of over 65, this is less represented in the numbers, and approximately less than 5% of our patients are in the extremes, in the above 65 age group. As you can see, we are achieving diversion. So on any given night, at least 40% of our patients are completely discharged, and an additional 40% distributed into one of these either community or outpatient services I was talking about. So 70 to 80% of patients do not need to attend ED on day of consultation, but the other 20 to 30%, which is again age-related, being directed into ED on where possible on one of these streamlined pathways. Our most common presentations are things such as abdominal pain, fever, cough, GI symptoms. A lot of these symptoms patients are struggling to get into their GPs with, particularly fever and cough because of the COVID situation at the moment. So we're 10 months down the line, and in this time, we've developed various pathways and collaborations with various community stakeholders as well. And what we've realized is instead of just a virtual ED, we're actually creating a virtual health community. And so we're at the point now where we're trying to work out where does this fit in, how big can we grow, and what impact does this have, and potential does this have for potential statewide rollout or development. But I guess given the context of this presentation, it did force me to have a think about what is the utility in the aging population, and are we actually offering a sufficient service to the aged care community. So currently within our healthcare professional pathway, we have two pathways in for aged patients and for aging patients. And one of that is with our residential aged care facilities. As I mentioned before, we do offer a bridging service for residential inreach. So when they close or out of business hours, aged care facilities are able to contact us. We will do a consultation. In most instances, we're able to keep the patient at home and then in the aged care facility and link them back into a residential inreach support the following day. The vast majority of things we actually see are things like falls. And we also have the opportunity for GPs to contact us and do some consultations. And we've been able to facilitate direct short stay admissions for investigation, or some hospital in the home admissions for things such as iron infusions. We also have the self-referral pathway. In the initial pilot that we ran, we safety netted patients over the age of 65 in the sense that they could contact us but we had a very low threshold to bring them into emergency. We've subsequently stopped doing that, realizing that a large proportion of the patients do actually qualify for continuing management in the community. Our oldest patient to date is 92 years old. And as the project has progressed, we have developed some links into community specialist and GP pathways. So some examples of patients that we have seen in the more elderly spectrum. So we've managed an 81-year-old lady, for example, who had known heart failure, who was getting worsening peripheral edema and had recently seen her GP, who had advised that she starts using compression stockings, which she was finding really difficult to use and to put on. Realizing that she didn't actually have an imminent emergency problem that needed to come into ED, we were able to link her into our community teams, who were able to do a home visit, link her into supports, link her into our heart failure service, and update her heart failure plan with her GP. Another great example is a 92-year-old gentleman who contacted us with his son's assistance, I'd say, who'd been having some loss of appetite, some constipation, and some general physical decline. And we were able to bring him in the next morning when it was less busy for a direct admit to short stay for investigations, including bloods and imaging. And he landed up having, unfortunately, some metastatic cancer as his diagnosis, but spared him an unpleasant evening in a very busy emergency department. In terms of barriers to utilization of the service, particularly thinking again more in the elderly space, we acknowledge that use of technology can be a significant barrier. Certainly the advertising we've done of the service hasn't been particularly targeted towards the elderly population. While we have done some very specific brochures for residential aged care facilities, most of the advertising comes out of our short stay, fast track and pediatric departments, and most of the patients entering those services would be on the younger side, sort of under 50s. Again, barriers with non-English speaking background patients, particularly elderly non-English speaking background patients. We do offer interpreter services in the for the consultations, but the registration itself is in English. And as I mentioned, all the advertising is in English. And we realize that there is an underutilization by healthcare professionals, particularly the GPs. But I guess there's also been, in self-reflection, a bit of underdevelopment from our virtual ED team, probably related to some heightened concerns about managing this age group in terms of its complexity and how to ensure that there's adequate safety netting for these patients. In terms of enablers, while technology may be a barrier, certainly we have seen in COVID an increase of technology use in the elderly age group. And this has become very evident both in the outpatient space, but also just patients using it for family communication. Advertising has been targeted slightly more. So we have been asking our surgical teams to hand it out to post-operative patients. And we have noticed an increase in uptake in patients having surgeries with some complications contacting us for advice. But also just word of mouth has enabled the service to develop more. We have noticed that although they might not always be technologically advanced enough to use the service, a lot of family members are sitting with their parents or grandparents or uncles and aunts and helping to assist them to utilize the service. And we've had reasonably good residential aged care engagement, particularly with a certain cohort of facilities near us who've quite enjoyed using us, and we've noticed that they tend to use us very frequently. So moving forward, where do I see us assisting to improve the service for all age groups, really? Certainly, the technology interface would be great to improve. We've talked about, particularly for aged population, having design features such as increased font size, increased ease of use to try and assist engagement. In addition to that, having the ability to have different languages would be absolutely ideal. We know that the technology is improving, but we're just not quite there yet. We need to develop some increased pathways to support this aging population and really think about how else we can link them into community services without necessarily having to come into ED. target the advertising so that it's more available to all populations. And we've also thought about, how do we target barriers to greater healthcare professional use, particularly the GPs, and trying to work with them to recognize the utility in the virtual service in trying to keep their patients at home. So that is our virtual ED. I'm happy to take questions at the end, and I will hand over back to you.
Great, thanks very much, Loren. Really interesting discussion around, I guess, the underlying themes of integrating care across various different settings. So lots to explore there, and something that we picked up on with the Royal Commission work last year as well. So nice to see all these segues coming through. Our last and final speaker for this afternoon is Dr. Don Campbell. Dr. Don Campbell is Medical Director of Hospital Without Walls and Staying Well program at Northern Health, and is also an adjunct professor of medicine and a professor in the Faculty of Art, Design and Architecture at Monash University. And I guess Don's going to be talking to us about Patient Watch and some of the other work happening at Northern Health. So over to you, Don.
Thank you, and I'll just attempt to share my screen. Thanks very much, Bianca. I hope you can all see this screen now, and it should. I'm just going to go back to the first one. It won't be tick here. Okay, I'm going to talk to you about Patient Watch and building the hospital without walls out here at Northern Health. We got an opportunity presented to us to put together a program and to think differently, to think outside the square perhaps. And we took some inspiration from two people, the Cynefin framework, which is a way of thinking about things through the lens of complexity science. On the right-hand side, we've got the simple leading into the complicated, the known and knowable part of the universe, and a strategy built on sense and analyse and respond. And on the left-hand side, complexity and chaos, but just focusing on the complex sphere where the approach is to probe, sense and respond. And what we should have done is always absolutely clear in retrospect. So the other thing that we've taken a great deal of interest in is the Buurtzorg model of community nursing in the Netherlands, which builds on self-management, trusted relationships and networks for team-based care. And the argument there is that the community-based nurse has a central role and knows best how to support the client in their specific circumstances. Our model is really that patients are at risk of, what we're looking at is a model based on detecting people who are at high risk of frequent hospitalisation in the next 12 months and using two algorithms, one that was provided to us by the department and another that was built up internally by a team led by Anthony Gust. The combined use of these algorithms was to basically so we could minimise false positives and concentrate resources on the highest risk patients. This has generated a cohort of multi-morbid, middle-aged to older people with complex care needs. And as we learned, many have a history of trauma, and not surprisingly, many are low on the socioeconomic scale. I'm just trying to work out how to move that slide forward. Oh yeah, down there. The patients, how it works is patients agree to participate and they will receive a phone call from a telenavigator who is supported by the health coach. The telenavigator is a non-clinical person who calls the consumer and their carer typically weekly and conducts a health check with a pro forma of questions about the patient's self-perceived health and any concerns. The conversations are coded into a decision support system, and this generates alerts if the consumer's health is declining, and the problems and actions arising from the alerts are tracked in the same system. The health coach is a senior nurse or allied health professional. So we've got a lay person on the front line supported by a health coach who assist with navigation through the system. They triage the calls and support the tele-navigators, and they do the outreach into the home and provide the coaching and brokerage services where necessary. Just to show you how this model works, the tele-navigator acts as a professional neighbour, and they have a cycle of calls. The information is coded into a decision support system. The backup is provided by the health coach, and the responses are both anticipatory and reactive and draw on the variety of services that are available in the community. How it works is that the patient watch is not a time-limited service. Patients are reviewed every 90 days to see whether they would benefit from staying on the system. Patient can stop or start as they see fit. And for medical matters, there's a strong focus on encouraging patients to see their GPs and their specialists and to not go to the ED. And the health coaches and the tele-navigators are often called upon to help navigate this system. Support with transport bookings and coping with anxiety is a common feature of the service model. Over time, by having a consistent coach and navigator, we generate a deep understanding of patients and trusted relationships are formed. The intention here is to help the patient self-manage to the extent that's feasible, and social prescribing is part of the model. We've learned a lot from running this system now. It operates between in working hours, business hours, so-called. Patients and carers can call patient watch at any time, and the participants continue to use the ambulance for emergencies. And we note that hospitalisations in this group of people may well be necessary and appropriate. The staffing is of 5 EFT and of telenavs and 4 of health coaches, and we anticipate that this team will be able to carry 350 patients at any one time once we've ramped the system up, increasing as the digital health solutions are introduced into the model. And our rate of turnover, we're currently learning our way into that. So eligibility is for a funding model that is within the global allocation for our health service. It's not additional funding. Is generated by the HLCC algorithm and the algorithm generated internally. They're not eligible if they live in an aged care facility. It's got to be safe for staff to visit at home, and they can't be under the long-term care of an alternative comprehensive program. We make broad use of a wide range of existing internal and external service providers, and these providers also are in the space of providing community and home-based care and can include Northern Health acute services, in particular the ED and mental health services, and access to Ambulance Victoria. So our performance to date, as to the end of June, we had 233 people who had were participants. We'd graduated 34, and we had almost 200 on the books at that time. And we had, in addition to the 233, had also worked our way through an additional 600 people. We had a couple of losses to follow up. We had a group who had declined the opportunity, and we had people who, frankly, it was not safe to go into their houses. We have 154 on the runway to get in, and there's the frequency of self-rated health calls and alerts generated from those calls and actions arising. So it's quite an active watching model. The next steps are to ramp up the patient load, to undertake a formal evaluation, to use smartphones and SMS self-rated health checks. We're going to pilot passive home monitoring and scale up a second team. We have identified the need to further assist people who've had trauma in their lives. And what we've noted is that the 4 Ps unite this group of people: loss of purpose, pain, pressure manifest as depression and anxiety, and self-medication with pills and booze. We want to extend the reach of this approach to the rising risk cohort, and we're currently working, or at least Anthony Gust is working on a machine learning algorithm to detect these rising risk cohort. We want to further develop the pathways in addition to support the dying well. So we had set ourselves a target of a 20% reduction in bed day use compared with controls. We have exceeded that in the cohort to date. We want to make sure this is sustainable over time. The challenges are really to train up the lay people at the front line, and to tap into the informal care systems to better support people closer at home, and to look at how we organise and deliver care, to build out that digital infrastructure. And as you saw from Loren's presentation and from Rebecca's, a digital approach is going to be absolutely necessary. We want to be smart about how we do this. And here we've got the different ways you can scale stuff up. Shouldn't have said stuff up in the same sentence, but you can scale things up. You can be dumb, you can be slow, you can rush, or you can be smart. And we want to be smart about how we do this. What won't work? More assessments, tight control, focusing on problems, and the thinking that we've used for the last 20 years, because that's how we got to here, and it won't get us to where we need to be in the next 1 to 5 years. So we need to look at this complex adaptive systems thinking, focus on resilience, get good people up the front, build the self-managing teams, and coach the team rather than attempt to hierarchically manage the team. So there's some references, and I thank you for your attention. If I knew how to do this, I'd do that.
You've done it, Tom. Yep, no, thank you. I'd ask Loren and Rebecca also to come back online. Fantastic. Thank you for 3 really very well interconnected and complementary talks about some kind of on-the-ground innovations that are happening at Northern Health. Now is our time to ask questions and explore topics that we might have not had a chance to delve into as yet. While we're waiting for a few questions to come up in the chat, I've got many questions, but I will try and restrain myself to at least one to start with. And this is both to Loren and to Don around integrated care. And what struck me about both of your talks is the need to integrate care, not just across acute care and primary care services, but very much along integrating with informal care services and the sort of social prescribing. So a much more holistic approach to how we might have conventionally thought of these things.
Loren, do you want to go first? And I've got some thoughts about it.
Well, yeah, sure. I mean, I think what's been very evident with my project is that there's a lot of overlapping and redundancy, but there's also in some aspects of healthcare. But at the same time, there's a need for us to get patients who fall through the gap because we're not working collaboratively and across the networks and with all our community services. And so I guess the focus of my project is how can we work with our partners to make sure that we are being innovative and using technologies to support patients as much as possible. And as Don says, think out of the box to try and live in a virtual world where patients can actually receive a lot of their care virtually and in the convenience of their own home. But it's also the integration across the organization. So, I mean, yes, we're working with community stakeholders and all that kind of stuff, but also realizing that, for example, my work and Don's work complement each other. And we have found ways that our patients can, be assisted using each other's resources. So I think the focus on all going forward is to be thinking about things within your organization that, complement and work together, thinking about community stakeholders that complement and work together. And, in my utopia, we actually think statewide and start thinking about much bigger stakeholders where patients, we can offer patients virtual care without redundancy and overlap, but also more targeted purpose. And, we're at the moment working with Ambulance Victoria and, much larger organizations to see where we can actually develop this virtual space. Yeah, I think does that answer your question, Bianca?
Okay. I would add in, we are learning our way into this, and I think that an integrated care model, including the social prescribing, means that we need to be able to identify where the social services are and to connect with them around individuals. So it's very contextual and very individualised. And here at Northern, what we've looked at, we've got Patient Watch on the inside of the hospital, and our community partners are developing Community Watch. And we're trying to build, my metaphor is we're building the Sydney Harbour Bridge from both sides at once, and we're trying to join it together. And just in our district, for instance, those social support services in Craigieburn and in Whittlesea are going to be very different from in Thomastown and Laylaw, and different again from in Glenroy and Broadmeadows. And it requires local contextual knowledge, which is why I'm attracted to that Buurtsorg neighbourhood community nursing model, where it's a self-managing team, not a hierarchy. It's a self-managing team, but we've got the good digital links to connect in. And if I could use an example from another setting, working with Loren's team and with our eye ophthalmologist, we were able to organise a telehealth consult into the home for a person with a red eye who would otherwise have needed to call an ambulance and come to an ED, taking 2 services out, imposing a huge burden on everybody. And then we were able to turn around and could have prescribed medication and delivered it into the home. So we're really rapidly learning how to think differently. And it's been very important to get some contextual understanding of the different cultural and linguistically diverse communities. And Rebecca's insights that she's been able to generate for us as to how these diverse communities access knowledge. Thank you.
Thanks, Tom. That's a really comprehensive answer, and we're big fans of the Buurtsorg model as well. It's been widely used and one of the good examples of integrated care as well. But that's a good segue to talk to Rebecca about some of the work that you've been doing, Rebecca, and it's certainly a topic that's close to my heart in terms of working with culturally and linguistically diverse populations. I've got a slightly curly question, if that's all right. Sorry.
I promise I'll be able to answer it.
I'm sure you will. Look. So first of all, absolutely commend the service and the innovation around building, as I said before, a culturally safe service to increase vaccination and overcome vaccine hesitancy. And trust is really integral to that. My curly question is also about a lot of the populations in the northern suburbs. Yes, they're high migrant populations. They're also relatively young. And, the vaccine rollout at a federal level and the state level have had these kind of age limitations around who is accessible, when and where, and it's only really recently opened up. So how much of this is vaccine hesitancy in the population, and how much of it is actually a structural eligibility issue?
That's a really good question, Bianca. So we have probably 3 fairly distinct migrant groups based on migration patterns. So we've got a large population of Southern Mediterranean Europeans that have come post-World War II. So Italians, Greeks, we've got a lot of Turkish, Macedonian. So they sit in this bracket very, very much so. And we're still seeing a lot of vaccine hesitancy. That population tend to get their information from their children and rely on their children very much as a source of trusted information. And those children are getting their information still through social media. So there's that aspect of it. Then we've got less large but still sizable population from Asia. So we've got a large Nepalese migrant population, some Chinese, and so you possibly saw WeChat was one of the large sources of information, and a large Vietnamese population. And then we have the more recent migrants are the refugee groups, which are largely from the Middle East, so Syrian, Iraqi, we've got a lot of Iranians as well, so Persian speaking. And so our strategies have to be different because the groups are different and the way they're accessing information is different. And so we're trying to tailor that. We do still have, even though, as you say, there's a younger group that haven't to this date to potentially been eligible, there is still quite a lot of over 40s in that refugee population, and there are older refugee, so the family groups that have come with grandparents and on assisted visas or family visas. So they're really diverse, and there isn't actually a one-size-fits-all method for targeting them. But we are trying a range of different ways to reach into these communities. And I think as the best we can do is continue to try to communicate with organisations that are working with these communities and trusted leaders, and try to identify what the best means of doing that is, and that's all you can do. I don't know whether I've answered your question at all.
You've given us good insights. That's an important start. Look, I don't think we've got any additional questions at the moment, so we might I might just invite the audience to please join me in thanking our three speakers today with their virtual claps. So we thank you very much for your time and for sharing your insights and knowledge. Next week, we will have Dr. Belinda Gash, who will be presenting on exploring the impact of rurality on aging and caregiving. And we look forward to seeing you all then at 12 p.m. So that brings us to the end of today's session. Thank you all very much for attending our program, and have a lovely day.